All right. Good morning. Today we're going to talk about fluid management. In particular, I want to talk about how salt and water move through the different body compartments. And the reason to go through this is the ultimate goal here is to understand body fluids enough that we can write a rational and intelligent IV fluid order. So that's sort of the end result here. Just as a reminder, about 50 to 60% of our total body weight is water. Men skew towards the higher end of this, and women towards the lower end of this. And the difference is primarily based on a relatively higher muscle mass in men and relatively higher body fat percentage in women. As a point of reference, babies, a neonate is about 80% water by weight. As far as this little chart goes, it shows things here in percent. So I personally think of it more in fractions, but whatever works for you. In the intracellular space, that's where about 2/3 of our water exists. And in the extracellular space, about 1/3 of our water is there. And then in this extracellular space, that's further subdivided into two components: the plasma space here, which is often the space clinically we're most interested in. That contains about 25% of the extracellular water. And then the interstitial space, the space between the capillary and the cell, contains about 75% of the extracellular water. So much of our water is locked up in the intracellular space. In that space, potassium and magnesium are the principal positive charges, and phosphates and proteins are the principal negative charges. So this intracellular space is an extremely different space than the extracellular space. And those differences in ionic compositions are based on this semi-permeable membrane, this sodium-potassium sort of energy-dependent pump that works actively to keep sodium ions out of the intracellular space. But it is important to remember water goes everywhere. So water is freely diffusible across all cell membranes, and it follows its concentration gradient. The extracellular space is where about 1/3 of our water is located. And again, it's subdivided into these the two additional spaces, the plasma volume and the interstitial volume. In this space, sodium is the principal cation, and chloride and bicarb are the principal anions. Now, it's the capillary membrane that separates the extracellular space into its two components. And the unique characteristic of this membrane is that it has pores. In general, these pores are small. And so small molecules like sodium or potassium or glucose can freely move through these pores. And so the concentration of these substances is the same in both the plasma space and the interstitial space. However, large plasma proteins like albumin, for instance, at least in conditions of health or normalcy, cannot get across the capillary wall. The pores are too small. And so that makes plasma proteins particularly important in this space, in the same way that sodium is so important for the extracellular space. And we'll talk about this a little bit more in a second. So this picture, I think, sums it up pretty good. For the extracellular space represented up here, we've got this membrane with these pores. And really, all the colors look the same. What you notice, however, is that there's a large amount of plasma proteins in the plasma space that don't exist over here in the interstitial space. By the same token, the difference between the extracellular space and the intracellular space, for our purposes, is going to be sodium. It doesn't exist in any appreciable quantity in the intracellular fluid. So sodium is going to become a very important substance for us. If you look at all the IV fluids that we use, they contain various amounts of sodium. And it's that amount of sodium that's going to govern ultimately how these fluids are distributed throughout the body. What we're going to care about a lot when we're talking about how fluids move around the body is the osmolarity of different solutions. And so when we describe something in osmoles, we're really talking about the number of osmotically active particles that exist in a solution. And how osmotically active something is not dependent on its size or weight, and nor is it dependent, excuse me, on its chemical combining activity. It's basically numbers. So one molecule of albumin has the same osmotic activity as one sodium ion. It's simply a numbers game. All right. As far as these different fluid compartments, although they are very different from a chemical standpoint, they have the same number of osmotically active particles, roughly 300 milliosmoles in each of the different body compartments. This osmolarity is made up of all the partial pressures of the solute, of each solute in that fluid. But ultimately, what we really care about clinically is what's called the effective osmotic pressure. And that's the substances that don't pass through the membranes. So we care about plasma proteins in the extracellular space because these proteins in general don't pass through the capillary membrane. And when we're speaking about the difference between the intracellular space and the extracellular space, we primarily are going to be talking about sodium because that's actively kept out of the intracellular space by the membrane. Now, sometimes other substances can play a role here. Someone with a diabetic ketoacidosis, for instance, they may have a glucose of 700, 800, even 1,000. And that glucose is limited to the extracellular space because it can't get into the cell. And so you'll find water moving into the extracellular space because of the high amount of glucose. And sometimes in renal failure patients, urea can play a similar role. So although today we're primarily concerned with sodium because that's what's in IV fluids, other substances can be osmotically important as well, depending on the circumstances. And so sodium contributes most of the effective osmotic pressure between the intracellular and extracellular spaces. And proteins, dissolved proteins in plasma are responsible for the difference between the plasma space and the interstitial space. Sometimes you'll see this referred to as the colloid osmotic pressure, or sometimes even the colloid oncotic pressure. In any circumstance that alters this relationship will allow water to move between the different compartments to make the osmotic pressure similar. All right, let's talk a little bit about sort of, the checks, the input and output of water. Normally, we'll get our fluid on a day-to-day basis, clearly from stuff that we drink. That can vary from day to day. Some days it'll be less. Friday nights, it's likely to be more. And then we get a fair amount of water from our food. Fruits and vegetables are almost 100% water by weight. And so there's a lot of water locked into those kinds of foods. And so that contributes a fair amount to our water balance as well. Water from oxidation simply means that carbohydrates, particularly glucose, are oxidized to CO2 and water. And so we get a certain amount of water through glucose metabolism. As far as output, we lose a certain amount of water through our skin and lungs, more through the skin than the lungs. About 75% of this insensible loss is through the skin. Insensible simply means that we don't have a good way of measuring it. You can lose a small amount of water under normal circumstances in the stool, although in cases of pathology, you can lose liters of water through the stool. And then urine output makes up the difference to keep everything sort of in balance. So as we go through our day-to-day lives, we don't think about this too much. We eat and drink as we see fit. And ultimately, our kidneys sort all of this out to keep our water balance at a relative net zero. There are some circumstances, however, where we can lose more water than we might necessarily suspect in the hospital setting, or I suppose even at home. If you have, a bad flu or something, for every degree of fever, you can lose approximately 150 mLs per day. This is pure water. It's not typically electrolyte water. During a laparotomy or a thoracotomy, when you have the chest or abdomen wide open, you can lose as much as 1 liter per hour through the peritoneum. At the end of a case, we usually ask the anesthesiologist how much fluid they gave. And if it was a 4-hour case, we would expect to see them give roughly 4 liters of fluid because they know this physiology as well as us. And so, if they only gave 2 or if they gave 6, that would demand some kind of explanation as to what might have been going on during the case that they gave less than we would expect or more. But we lose a fair amount of fluid during surgery. Now, to clear the products of metabolism, urea and other substances, the kidneys really have to make 500 mLs of urine a day. That's when they're maximally concentrating. That's when they're working at peak efficiency here, which ultimately means that our minimum water intake from any and all sources has to be about 500 mLs a day. We can take in a whole lot, but we need sort of a minimum of 500 mLs a day, or else we're going to have a very difficult time excreting what we need to excrete and ultimately end up in renal dysfunction. Besides water, we need to care a little bit about salt since the movement of water is throughout the body is highly dependent on salt. The recommended daily salt intake is about 50 to 90 milliequivalents, which corresponds to a 3 to 5 gram sodium diet. Of course, the Western diet tends to be much higher in salt than this, with people generally bringing in more than 100 milliequivalents and maybe as much as 250 milliequivalents a day, which is anywhere from a 9 to 12 gram sodium diet. So we tend to really overdo it on salt. The balance is maintained by the kidneys. The kidneys are highly, highly efficient at getting rid of the excess. And if you were in a situation where you were taking in no salt, the kidneys are able to concentrate this exceedingly well and hang on to sodium. And so almost, essentially excreting no salt if the circumstances dictate it. All right. one decision we have to make when we see a patient is assess their volume status. Are they fluid overloaded? Are they dry? Are they euvolemic? And most of the time, this is a pretty straightforward um, analysis to make. But every once in a while, it can be really, really difficult. And the challenging patients tend to be ICU patients uh, who, have underlying illnesses that make them hypervolemic. Let's say they're cirrhotics or in renal failure, who then develop a surgical problem where hypovolemia becomes a challenge. And so trying to decide whether a patient whose total body water is very high is intravascularly depleted can really be a very difficult clinical judgment. The greatest majority of surgical patients present with a extracellular volume deficit. They're hypovolemic. And we see this in an enormous number of settings. Patients with gastric outlet obstructions can lose a lot of fluid through vomiting or through an NG tube. The baby with pyloric stenosis can lose a tremendous amount of fluid relative to their body weight. Someone with C. diff colitis can lose fluid. And then we see a whole bunch of different fistulas as well. So all of these result in losses. And then there's the problem of sequestration, or sometimes called third spacing, where we're not losing the fluid, we're just moving it into different spaces where it's less available to the body. So an extensive burn wound can sequester liters of fluid in that burn wound. Patients with bowel obstructions are able to sequester liters of fluid, not only in the lumen of the bowel, but inside the bowel wall as well. Patients with peritonitis or pancreatitis can do a similar thing. And then, of course, we have our trauma patients that can lose blood. So most of the patients we see are going to present with an extracellular deficit. But how much that deficit is difficult to know. There's no formula to accurately estimate this deficit. There's no particular lab test that's going to tell you what the deficit is. It really becomes a clinical judgment. And so how do we make this judgment? Well, the mechanism is usually our first clue, and that tells us much of what we need to know as far as how much fluid a patient may have lost. Other clinical parameters can be important. Tachycardia, hypotension, perhaps collapse, neck veins, poor skin turgor. These are all clinical signs that sort of clue us in as to how extensive that volume deficit may be. And then, of course, we measure urine output. We use urine output as a surrogate for organ perfusion, and oliguria is what we tend to follow and try to improve in our hypovolemic patients. As far as different lab assessments, these are not necessary in all patients. I'd say most patients would merit a BUN and creatinine, but measuring something like urine sodium or the fractional excretion of sodium definitely have their uses, but far from routinely necessary. ICU patients, where we're struggling to know whether the patient is wet or dry, are the most common uses of these kinds of labs. Base deficit and lactate level can go along to help us out a little bit. We don't have invasive monitoring very often in our patients anymore, but a low CVP or a low cardiac output obviously would be useful information if we had it. And one very useful thing in the ICU is daily weights. Many of these ICU beds nowadays have accurate scales built in, and patients who are gaining or losing weight on a daily basis, it's almost always going to be related to fluids. The management of a hypovolemic patient is generally pretty straightforward. If they're bleeding, well, we need to stop the bleeding. If they have sequestration or frank losses, then we have to make up this deficit with our IV fluids. Our ultimate goal here is to try to get an adult patient to a half a cc per kilogram per hour. In smaller children, we're generally shooting for a little bit more urine output, usually a cc per kilogram per hour. As we know, if we underdo this, our patients will have poor organ perfusion. In particular, their kidneys will start to fail if we're not careful. But overdoing it is also bad as well. Too much fluid can ultimately lead to heart failure and pulmonary insufficiency and make it, much more difficult to get a patient off the ventilator. And I guess one personal pet peeve of mine is if you think that a patient has a volume deficit, don't give them diuretics, okay? You will squeeze a little bit of urine out of this. It's kind of like wringing out a sponge. You'll get a few more drops, but you'll make the problem worse. Clinically, you have to decide whether the patient's wet or dry. If you think they're dry, they need fluids. If you give them fluids and they still aren't making urine, then they may well need more fluids. But it's pretty schizophrenic, I've always thought, to give someone a liter of fluid, get don't get the results you were thinking you were going to get. And then you say, well, I guess they must be wet, and give them a diuretic or something. That is usually not going to be the right management for a patient. Make a call. They're wet or they're dry, and have the courage of your convictions and just see it through. As far as patients with hypervolemia, these patients are less common on a surgical service, but not completely uncommon. If you're on the cardiac service, a lot of your patients will have too much fluid. A lot of times this will be iatrogenic. Patients who need massive fluid resuscitation, like some of our trauma patients or septic patients or burn patients, are going to get a ton of fluid. And so ultimately that's going to be a challenge down the road, but the resuscitation demands it. So we make many of our patients hypervolemic. And then of course we take care of a lot of medical patients who are hypervolemic to begin with. And so a patient on a medical floor with heart failure or renal failure or cirrhosis sometimes develops surgical problems. And so we have to be involved in these type of patients as well. So although hypovolemia is more common, we definitely need to know how to deal with the hypervolemic patient as well. The assessment for this kind of patient is pretty straightforward. There usually be edematous. If they had some kind of central access, they would have a CVP that's elevated. Pulmonary edema or a fluffy chest x-ray is usually useful evidence as well. And then weight gain. A patient who's gaining a half a kilo to a kilo of weight a day, it's almost always going to be fluid. So weights are a very useful way to assess fluid status in our patients, especially in ICU type patients. And the management of a hypervolemic patient, again, is once you understand that they're hypervolemic, is generally pretty straightforward. The simplest thing you could do is decrease their IV rate, and that might be sufficient for some patients. Other patients are going to need diuretics if their kidneys are working. And then lastly, if you've got a patient who's in renal failure or is already a dialysis patient, the only way you can get the volume off is to dialyze them. All right, let's with that as a little background, let's talk about IV fluids and how we might think about using them. So here's a chart that shows the sort of common fluids that we use with their electrolyte composition. And most of the fluids we use, as you can see, just contain sodium and chloride. The one difference is lactated ringers down here. Lactated ringers is designed to be an extracellular fluid type mimic. And so it has a little bit of potassium and calcium in it. The bicarb here is the lactate. We don't call it bicarb ringers, it's called lactated ringers. And the lactate that's in this fluid is converted in the liver to bicarb. The 50s over here represent the amount of glucose, that's 50 grams. We'll talk about why you might want to use glucose in a second. But these are the general fluids we would use. Hypertonic saline has a specific use case. It's often used in cases of massive fluid resuscitation, for instance, as a way to potentially limit volume. So hypertonic saline will end up pulling fluid from the intracellular space. So you're sort of using it to auto resuscitate yourself. You're pulling water from the intracellular space and using the intracellular space as kind of a fluid bank to help in the resuscitation. And of course, ultimately, you're going to have to replace that fluid that you borrowed from the intracellular space. All right, now we can think about fluids in sort of two ways, so-called replacement fluids, or the other use would be maintenance fluids. So let's talk about replacement fluids first, and these are going to be isotonic fluids. These are going to be fluids that have roughly the same osmolality as serum, which is roughly around 300. So if you go back here and do some basic math, you'll end up with pretty close to 300. And the same with LR. So these are what we will call isotonic fluids. They're used to correct volume deficits. And this is because they are limited to the extracellular space. The membrane, the sodium potassium membrane will keep the sodium out. And if sodium's kept out of the intracellular space, water is kept out of the intracellular space. Now, which one of these fluids is better? Is there any difference between LR and normal saline? And I mean, if you ever did a PubMed search on this topic, I mean, you'll find innumerable articles. I mean, probably thousands, trying to sort out, when do you use LR? When do you use normal saline? Is one better than the other? And I think to sum it up, at least for me, they're completely equivalent. They accomplish the same thing. And so I don't think in the vast majority of cases, it really matters which one you use. Now, there's a few theoretical advantages to using one over the other. Since lactated ringers has bicarb, some suggest it may be a better choice in acidotic patients. So that might be one use case where you think, well, maybe LR is a better choice than normal saline. By the same token, LR contains a small amount of potassium, and it is a small amount. But if you had a renal failure patient or, a patient with rhabdomyolysis, maybe you'd want to avoid any and all potassium. And so you might want to avoid LR in a renal failure patient. And lastly, high volume normal saline, like you might see in a burn resuscitation, has been associated with hyperchloremic metabolic acidosis. So I guess with that as a little background, you could make a choice between one or the other. But near as I can tell, they're really the same, and they're used for the same purpose. Another type of fluid that we might use are colloids. These are large molecules. 5% albumin is the most common one we use. Hespan is a large starch molecule that is sometimes used in the OR as well. What's the point of these things? They're large molecules, and so they should not pass through the capillary pores. And so they're relegated to just the intravascular space. So when you just want to resuscitate or increase the intravascular space, these would be theoretically very good choices since they should not move into the interstitial space where, and remember that interstitial space is 75% of the extracellular space. In certain cases, we would like not to have the movement from the intracellular space into the interstitial space. So the point of these colloids is to stay in the intravascular space. Now, does that work is the big question, because it's never been shown that using colloids, in sick trauma patients, ICU patients, has ever resulted in a better patient outcome. And it turns out that that in inflammatory conditions like our burn patient or our trauma patient, these pore sizes increase. And so these molecules that we think are going to stay in the intravascular space ultimately do not. They're able to move into the interstitial space as well. So when do we use these things? They're used in the ICU, they are used in the ICU, but they're also used in the OR. Anesthesiologists like these fluids, especially in cardiac patients, because it's a way of restricting volume in patients who can't handle volume. So that would be the major use for these things, is in people who just couldn't handle volume. But if they have a strong inflammatory response, like many of our patients do, like a septic patient will, then that probably defeats the purpose, because the pores will be big enough that ultimately you're just making expensive edema fluid, because these large molecules will be able to go into spaces that we don't think that they belong. All right, maintenance fluids are usually given as D5.45. And so maintenance fluids are used when a patient is euvolemic. And so we're just sort of giving them what they need on a day-to-day basis. And the most common maintenance fluid is called half normal saline, either D5 or just 0.45 normal saline. And so I think of this as a combination of normal saline and free water. In fact, that would be one way that you could make this. If you were going to make normal saline, you'd take 9 grams of salt and you'd dissolve it in a liter of water. And then if you wanted to make half normal saline, you could take that batch and then add the same volume of water to it. Basically, you dilute it by half. And so these maintenance fluids that we use are half free water and half normal saline. And the free water's component is important because that's replacing the insensible losses that we have that we can't measure. That's essentially water vapor. And so replacing that with free water makes sense. And then the other component, the normal saline component, provides sufficient salt, of course, and then takes care of providing the fluid we need in the extracellular space. Now, why is dextrose added to some of these fluids? Like we typically will write for D5.45. And so what is the point of this dextrose? Well, I mean, it gives 170 kilocalories. If you remember, dextrose is 3.4 grams per kilogram. So we get 170. And the idea is that at least in a non-injured or a non-inflammatory type patient, this may limit protein catabolism. Remember, we talked last week about a patient who's fasting. If we give them nothing at all, then to make glucose, they're going to have to catabolize some protein to do that. So the idea here is we give them some glucose in a sort of non-stress situation that will limit protein catabolism. That's the intent here. That probably is legitimate in many of our patients. But again, the patient who has the strong inflammatory response, which many of our patients do, this isn't really going to work. On the other hand, if you're giving a patient water or quarter normal saline, you have to give it with dextrose. And the reason for that is these fluids are so hypotonic that once you infuse them into the vein, it's going to cause red cell lysis. So some fluids, we just have to give dextrose, not primarily for the small amount of calories, but to prevent cell lysis. And then usually we will add some amount of potassium, usually 20 milliequivalents per liter, sometimes as much as 40. The reason for this is we have an obligate potassium loss every day. And so we want to replace that. And some of our patients, of course, have NG tubes and things like that. And they'll lose some potassium as well. So it's pretty customary, at least in a non-renal type patient, to add some potassium to the fluid as well. And then, how much do we give? What would be an adequate maintenance rate? And there's a number of ways to do this. If you remember from a few slides back, on day-to-day living, we take about 2,500 cc's of fluid in from all sources. So that's roughly, 100 cc's per hour. So that's a pretty reasonable starting point for a maintenance rate. Or you can take the patient's weight in kilograms and add 40. That gets you pretty close. On the pediatric service, you tend to use this 150-20 rule that's listed here, although that works perfectly well for adults too. So you can use this as well. But most of our patients, are going to be somewhere around 100 to 125 cc's per hour. In surgery, we tend to skew a little bit towards, the 125. Because some of our patients have NG tubes and other drains, so they might be losing some fluid. So a maintenance rate, depending on the circumstances, is going to be, somewhere between 100 and 125 cc's per hour. But you can be as exact as you want with a formula like this down here. And one last thing to consider is a lot of our patients are going to have some GI fluid losses. This might be through a drain or some kind of fistula, just a third space problem. If you have a patient with a C. diff, they can have extensive diarrhea. Different body fluids have different chemical and different electrolyte concentrations. The simplest thing you can do is just send a sample to the lab and get a BMP on it, and then you'll know exactly what you're dealing with. But there's a few things to note here. Lots of small bowel and pancreatic fluids, they really are sort of isotonic fluids. The sodium levels are pretty high. And so you'd want to replace them with a normal saline or an LR type fluid. And then notice over here, the bicarb levels are high. And so if you don't take that into account, your patient is going to develop a metabolic acidosis since they're losing bicarb. So usually you would want to replace the bicarb in these patients as well. Someone who has a large fistula, let's say 500 cc's or more, it makes perfect sense to me to write 2 IV fluid type orders. One order would be for the maintenance fluid, what they just need day to day, and the other would be a separate IV fluid order for whatever their output might be. So you could have a separate IV fluid order for the fistula that you've maybe added bicarb to it. And then the usual approach would be to replace that output on a cc per cc basis. So, if the day before they lost 500 cc's to the fistula, then you would write for 500 cc's the next morning, and then you would just adjust that as you go forward on a day-to-day basis. So conceptually, having two different IV fluid orders makes sense. You can certainly combine them into one, and that's probably the most common way people do it. But you really ought to think of it as two separate problems in any event. All right, just a few little questions to sort of drive home this idea. So this is an audience participation project here, so someone pipe up with the answers. But if you give a patient D5 water, give them a liter of D5 water through an IV, how much of that fluid is going to end up in the intracellular space?
About 40%, 30 to 40%, like 400 cc's.
Not quite. What's the ratio between intracellular and extracellular space?
70%.
Yeah, it's in a ratio of 2/3, 1/3. So the intracellular space takes up 2/3 or so of our water. And I'm not talking about weight here. I'm just talking about, we have two large spaces, intracellular and extracellular. And so that liter of water is going to be distributed, 2/3 of it is going to go into the intracellular space, and 1/3 of it is going to go into the extracellular space. So roughly this amount would go intracellularly. So you use D5 water when you primarily want to resuscitate the intracellular space, okay? Because the bulk of your fluid is going to end up in that space. All right, well, you give another patient D5 water, and we know that 2/3 of it ended up in the intracellular space, but how much stayed in the intravascular space? I mean, ultimately what we want to know here is every time you write a fluid order, where the heck is this fluid going? Is it doing what we want it to do? And do you think D5 water is a very efficient way to resuscitate a patient? Well, we know that 1/3 of the water is going to end up extracellular, right? Because we just talked about 2/3 of it going intracellular. So we know 1/3 of that liter is going to be extracellular. Okay. So now you got to think about what's the relationship between the intravascular space and the interstitial space. Those are the two components of the extracellular space.
Yeah, so 25% goes in the plasma and the rest interstitial.
That's true. So
of the rest of the six, like whatever was left from the 300 something.
Right. So basically you had 300 and something, and now 1/4 of that is going to end up in the intravascular space. Or another way of looking at it, 1/12 of that liter, however you like to do the math. So only a mere 83 cc's or so is going to end up in the intravascular space. So you can see resuscitating a hypotensive patient with D5, and we never do this, of course, and there's a reason why we don't, because if you just use D5 water, only a tiny fraction of that water stays in the intravascular space, okay? Most of it is going to go intracellular, and then the majority of the leftover is going to end up in the interstitial space. Only 1/12 of that liter ends up intravascular. All right, so you give this patient gets a liter of normal saline. Okay, how much stays in that extracellular space? So intracellular, extracellular.
Isn't it the same because they're both isotonic?
Yeah, exactly. It all stays in the extracellular space. It can't get intracellular because the sodium concentration here and the sodium potassium pump on that membrane keeps sodium out. If you keep sodium out, you're keeping water out. So if you give a patient, and this is why we give a patient normal saline, is because it stays extracellular. Okay, it will not go intracellular, and so that whole liter stays in the extracellular space. That's why it's our replacement fluid, why it's our resuscitative fluid, because it doesn't go into this large fluid sink, which is the intracellular space. So all of it stays in the extracellular space. Now, of that liter, we know all of it stays extracellular, but how much is in the intracellular, in the intravascular component of that extracellular space? Well, again, what's the ratio between the intravascular and the interstitial space?
25%.
25%, right. So 250 cc's of that liter that you gave stays intravascular, and 750 cc's goes interstitial. So what's the point? Well, even normal saline is not a very efficient resuscitative fluid. If you're most concerned about the intravascular space, you're going to give them normal saline, but only 250 cc's of that liter stays intravascular. The other 750 moves into the interstitial space. It goes a long way to explaining these resuscitative protocols that you see, Parkland formulas and stuff, where you end up giving massive amounts of fluid because only 25% of this isotonic fluid stays where we most prefer it would stay, which is in the intravascular space. So fluid resuscitation with D5 water is extraordinarily inefficient, but fluid resuscitation with something like normal saline is not terribly efficient either, in that 75% of that fluid goes where we'd probably prefer it not go, at least initially. So only 250 cc's of that liter stays intravascular. So if you give a maintenance fluid, D545, how much stays in the intravascular space? And the way I think about this is, what is D545? It's 500 cc's of normal saline and it's 500 cc's of water. And since we've talked about both these situations, if you just cut those numbers in two, you'd end up with, the answer.
About 200.
Yeah, slightly less, but you're on the right. It's 100. Where does 167 comes from? Well, remember, we just talked about 250 cc's of a liter of normal saline stays intravascular. 500 cc's would be 125. And then we have 500 cc's of water, okay? We talked about a liter of water and only, only 80 some cc's of a liter of water stays in the intravascular space. So cut that by a half because we're talking 500 cc's, add those two together and you get this number. So again, we don't use this fluid to resuscitate a patient as well, either. It's just not as efficient. All right, last one. You give them albumin, 250 cc's. How much stays intravascular? Well, what's the whole point of giving albumin or Hespan? Well, it should all stay there. The whole point of giving these large molecule substances that it doesn't pass through the pores. And so it should stay completely in the intravascular space. Now, we know that's not completely true. In a lot of conditions, sepsis and others, the inflammatory response makes these pores larger. So there should be a caveat that, the patient isn't septic or something. But the whole point of using these colloids is that it stays intravascular. And so you can minimize fluid resuscitation, or at least volume. To keep 250 cc's in the intravascular space with normal saline, you had to give them a liter. With something like Hespan, you could give just 250 cc's and it would stay there, except in a lot of our patients, that won't be strictly true. All right, enough of all that. Next week, we will talk about electrolytes. So onwards with all the exciting stuff. All right, thanks everyone.